It's a pleasure to introduce our next group, chaired by Dr. Jim Del Rosso, who needs no introduction, as well as Dr. Neal Bhatia and Dr. Linda Steingold, three great friends who are going to really give us a dynamic next 25 to 30 minutes of an interactive debate. And this is going to be really exciting to talk a little bit about the differences in rosacea and really get a sense of who in the room and who in our audience that we're streaming live to considers this a vascular disorder and who considers it an inflammatory disorder. Jim, I'm going to turn it over to you.
Thank you, Samal. And it's certainly a pleasure to have with me Linda Steingold and Neal Bhatia. Neal's from San Diego, a clinician and also involved with running a research center. And Linda from the Motor City, Detroit, the same, sees a lot of patients and runs a research center. I do the same thing in Las Vegas. And we're going to have what we call the Great Rosacea Debate. Is rosacea primarily a vascular or an inflammatory disorder? So I'm going to pass it over to Linda, who's going to start this off in the discussion.
Okay, well, good morning, good afternoon, good evening, depending on where you're viewing us from. This is really quite an honor to sit here with my colleagues and talk about something that I hold very dear, and that's rosacea. And I'm going to talk about the vascular component. I do clinical trials at Henry Ford. These are my relevant disclosures. So when we think about the pathophysiology of rosacea, there's really four pillars. There's the vasoactive mechanisms, we have the innate and adaptive immunity, and then we have the neurovascular mechanisms. And Dr. Stein Graf actually put together a really nice paper in the past year where he outlined the pathophysiology of rosacea. And if you just take a step back and look at the graph, the first thing that hits you is this is a really complicated condition. And actually, the more time we spend studying rosacea, the more complicated it becomes. But what we do understand is if we look at the two sides of the figure, we see on one side we have all of the neurovascular abnormalities that occur. On the other side, we have the inflammatory abnormalities that occur. And together we get a picture of a patient who has the signs and symptoms of what we call rosacea. Well, I'm going to take a look at the vascular side. I'm really going to look at it more from a clinical picture. And I'm going to let Neal get into the pathophysiology a little bit deeper. So when we look at the alpha-adrenergic agonists, for the first time, we can actually treat medically the vascular component. And we have two agents at our disposal. We have Brahmana Dean and we have Oxymetazoline. And the way these drugs work is they work at the Neurovascular Junction. And it's important to understand that we have different receptors in this particular junction. We have the alpha-1A adrenergic receptors, and these are the sites where oxymetazoline binds, and these actually occur only in the postsynaptic area. Then we have the alpha-2 receptors where Brahmana Dean binds, and these occur both in the presynaptic and the postsynaptic areas. By looking at this, it helps us to understand that different drugs are going to potentially react differently. So let's take a look at how are we going to treat this background erythema of rosacea. And when we take a look at the Brahmana Dean trials, these are interesting studies, and I'm just going to kind of walk you through how they're done, because I do clinical trials as these guys do. These are kind of difficult yet fun studies. So the way this study was conducted was you apply the medication once a day in the morning, and they looked at patients who had moderate to severe erythema, treating for 4 weeks, and then they follow the patients for 4 weeks. There's always two sister studies that are done simultaneously with any phase 3 clinical trials, because we want to make sure that the data is reproducible between the two studies. And these studies are kind of fun. You bring a patient in maybe at 6 in the morning, and they stay with you all day till 6 o'clock in the evening. What's great for the investigators is you actually get to watch what happens to a patient over the course of an entire day. It's tedious and time-consuming, but we actually get a lot of great data. Now, what's also interesting about these studies, I do clinical trials, and I've been doing clinical trials since I was a resident. In general, as the primary investigator, if I say a patient is a clinical success in that they got to a clear or almost clear with a 2-grade improvement, in general, what I say goes. That is it. In these studies, that's not what happens. In these studies, I might say, yay, thumbs up, good job, 2 grade improvement, clear, almost clear, but we also ask the patient. And the patient has equal say. And if they don't think that they got to 2 grade improvement, thumbs down, not a success. So it's very challenging to get both minds to agree and come to a meeting of the minds where we actually go at clinical success. But the FDA doesn't care, okay? They still want a 2 grade improvement. They want that full 2 grade. But all they ask for is a statistically superior difference from vehicle. They don't care what the delta is. Just make it. We know we put the bar up high. So when we look at how many patients got that 2 grade improvement at day 29, we see it was statistically significant at each time point. We also ask another question. How many patients had a 1 grade improvement? Maybe went from moderate to mild, or went from very severe down to moderate. That is a clinically relevant result. And here we see that we can get the results up into the 70s, and still a nice delta as compared with vehicle. And this is an example of a patient who was sitting in the office at baseline, followed them over the course of 12 hours, and we see a nice improvement. When we looked at the side effects profile, we did see slightly higher side effects in the Brahmana Dean group as compared to the vehicle. It's interesting to note that worsening of erythema in these clinical trials was only reported about 5 to 6% of the time. There was a long-term safety study that was done that found that flushing, about 9%, exacerbation of erythema, 6 to 7%. And this is something that we saw in post-marketing, that it did appear that patients were getting an exacerbation of erythema. We know if we treat the patient over the course of an entire year, we can actually get efficacy and maintain that efficacy over the course of the year. But what do we do with those patients who had that exacerbation of erythema? There have been some studies that were done that say, well, there are some things that we can actually do. In the studies, we use 5 Ps, 1, 2, 3, 4, 5. Too much. Don't use 5. Use 1 to maximum 3. Less is more. Less medication, less likely to have the exacerbation of erythema. Watch out for those patients who are the flushers and blushers. They're also more likely to have the exacerbation of erythema. We have another tool in our toolbox, Oxymetazoline cream. This was the second drug out for the treatment of background erythema. This one, it's interesting, not 5 Ps, 1 P. 1 P in 5 areas. So less medication was applied, but a very similar way. 2 studies were done, followed these patients. The endpoint is going to be day 29. Now this actually shows you the challenge of getting a patient and an investigator to both agree on a 2 grade improvement. On day 1, you see the 2 smiley faces under the pictures. That means both people agreed. And they both agreed at hours 3, 6, and 9, and then at 12 they didn't agree. That's okay. But what happened at day 29? Patient comes in with a red face, but the patient graded themselves as an almost clear. Oh my God, an almost clear? So by definition, there's no way they're going to get a 2 grade improvement. So that's going to be a failure just at the get-go of that particular day. But when we look, this drug also reached a statistically significant improvement in getting those patients the 2 grade improvement over the course of the 12 hours. When we look at side effects profiles, the drug was really well tolerated, and we didn't see any exacerbation of the erythema. So we talked about this a little bit before earlier today. Can we use a alpha-adrenergic agonist to enhance the effects of an anti-inflammatory drug? And this is really some breaking news, because we think of the two as being separate, the inflammatory component, the vascular component, but this study shows that there's actually some crossover there. And we saw that if we look at patients either starting ivermectin and Brahmana Dean at the same time versus starting ivermectin first and delaying the Brahmana Dean for a month versus vehicle for both arms, we found that actually adding the Brahmana Dean in up front actually controlled and got that IgA under good control. But stunningly, it appeared that the Brahmana Dean actually had a component in the inflammatory way, in that it helped to decrease the inflammatory papules and pustules better than using the ivermectin alone, especially when you started the 2 at the same time. So I think The vascular component is very important when we talk about the pathophysiology of rosacea, but I think there's a mixing of it, and the pathogenesis is much more complicated than we can really say. When we use these drugs together, I also want to make the note that the side effect profile diminishes significantly. We did not see the exacerbation of erythema with the Brahmana Dean when it was started concomitantly with the ivermectin. So thank you very much.
Yeah, Linda, I think it's important also in that particular study, the vehicle, the base of the topical ivermectin is very barrier friendly, and that may also contribute to helping reduce some of the potential side effects.
That's such an important point, because especially when we're talking about our rosacea patients, we've already talked about, you put on sunscreen on a rosacea patient, they say it burns. You put moisturizer on, they say it burns. So if you don't formulate a drug with a fantastic vehicle, you're going to have a problem with compliance as well.
We're going to move over to Dr. Bhatia, who's going to be taking more on the inflammatory side. Okay.
Yet suddenly I'm hungry for peas. Can't figure out why. So Linda painted a very good picture on the vasculopathy nature of rosacea, but I'm going to bridge the gap the other way and look at the inflammation story. And Dr. Steinhoff's graph was very complete. There's a nice picture of these two. And I think it all comes back to what is a rosacea patient struggling with, which is erythema. But it's not just static erythema, it's dynamic erythema. And flushing is what distinguishes rosacea from just physiologic blushing. And we all blush with different simple triggers, but that doesn't label us as having rosacea. A glass of wine, a little bit of extracurriculars, these are things that lead to flushing. But is that prolonged vasomotor reaction diagnostic of rosacea? And that's where, again, we get into situational treatments with those therapies that are anti-adrenergic as well as addressing erythema. The question becomes, does that make rosacea a vascular disease? And we flip it around and say, what is that actually that makes a trigger? Well, think about a hot beverage or coffee or caffeine or a stimulant that we list as triggers, that, the one thing that patients don't want to give up. What is it that changes the pH or the temperature in the oral cavity, sending messages to the carotid body, making a hypothalamic response, increasing the responses to thermal stimuli? Right? You see the changes in all that. We can't just say that those aren't somehow mediated by the immune system. And yet, again, we look at those as saying, yeah, these are triggers of rosacea, but where do we get to the formation of papules and pustules from that equation? So, again, going back to that bridge, and Linda showed that diagram, which I'm going to try to build on a little bit more in English. The idea is that, again, there's a bridge between the mediators, the stimuli, and some of these newer agents that are part of the process. We've all heard of cathelicidins and LL37 and some of the other matrix metalloproteinases as integral building blocks to the inflammatory cascade of rosacea. There's some newer components that are being better elucidated. And some of that, again, goes to the balance of, again, neutrophils, interleukin 8, and some of the other neuropeptides that are in motion. But this is probably going to be suspect number one as we learn a little bit more. This is transient receptor potential vanilloid receptor. And now it has me hungry for vanilla ice cream, my God. So if you look at its impact on interleukin 8 as well as some of the other components that make a papulopustular flare, all of that is cyclical, but it also is rolling downhill. And from that, there's also some predisposition. We talk about arrangement of genes. Is there a genetic predisposition that leads to that, or is there some other trigger that is promoting that cathelicidin cascade that we've heard so much about? And again, we look at the infiltrate and the inflammation in rosacea. It's not really around the glands like acne. It's not a pilosebaceous issue. It's more of a perivascular and a confluent infiltrate like you see under the microscope. But the bottom line is there's communication between the nervous systems, the immune triggers, and again, the vascular component, whether that's the primary, tertiary, or somewhere in between, is basically a communication issue that comes along with the development of rosacea. Now, this is a subset of that diagram that Linda showed before. If you look at what's going on in red, that's pathology right there. If you see the stimulus and a hot beverage or spicy foods, again, you have the activation of those molecules, but yet they're metabolized and they're processed in a normal fashion, and everything makes a normal response, like a physiologic blush, if you will. If you see the overexpression of TRPV, as well as some of the other neuropeptides that bring along with it, and then you look at the top where it shows the impact of thermal energy or capsation, if you will, as an irritant in the nerve endings, and plus also what it does to release substance P from the nerve endings as another mediator of pain, this might explain why that inflammatory component rolls downhill. From there, you can also see in that graph where TRPV is really having its best activity in that area around the papillary dermis, which again is correlating to the location of the infiltrate. So again, just trying to put together the building blocks, linking it to the nerve endings and where some of those release peptides are coming from, and also where VIP, vasointestinal peptide, shows its activity. All of that is a bit of a neuropeptide soup, as well as, again, the cascade of activation, like we've seen with cleaving of LL37 and the initiation of the IL-8 promotion of neutrophil activity. So from there, again, what's being understood is maybe the angiogenesis or the vasal component may not be as necessary in the pathophysiology early on of papulopustular rosacea, and some of these markers, CD31, which is important in the promotion of vasculature, as well as D240, which is being understood more in lymphatic vessels, all of these are working together as, again, working on the soup of inflammation that's bringing things towards a promotion of a phenotype, if you will. And what we're understanding here is that maybe only in the phymatous or the erythema telangiectatic rosacea components is there something that's more linked to angiogenesis. And again, we all hear about our patients who are red. They're static erythema, they look red, and this is where these agents that have been so helpful in reducing erythema have been very useful. But are they contributing to the process of what makes the disease roll downhill? And that's where I look at something like this that says, okay, where is a papule even made? And whether this is acne or rosacea, you look at the inflammatory component, where's their extravasation? There's also, again, release of the neuromodulators like substance P and some of those other neurotransmitters that promote interleukin 8 and the release of some of the other cytokines that promote reactive oxygen species and some of the true destructive nature of the dermal stroma. Is that why papules hurt, for example, because substance P is released? Because we know what an important mediator it is of pain, but it's not a pilosebaceous problem like we see with acne. So this is something from the October JAD where they were investigating the classifications. We talk about erythema telangiectatic, papulopustular, phymatous, glandular, all of the other different subtypes of rosacea, not including ocular, which is not part of the discussion. But again, is there something that says that the initial erythema is likely to be the start of that inflammatory cascade that's initiated by both the neurovascular dysregulation and the immune responses that promote cathelicidin biology? So the focus of some of the newer research is looking at, again, where does cathelicidin biology fit in? Where does that metabolism of those neuropeptides start and end? And where are our mast cells now showing themselves as part of the equation? Because that's the cell line that really wasn't understood as much. And if you take a step back, you think of mast cells as making itch. Well, most rosacea doesn't itch. It's usually more painful, or sometimes it's just more the vasomotor phenomenon of being flushed. So again, Dr. Gallo's the head of this article, and all of the contributors are talking about now reclassifying the components and the description of rosacea based on the inflammatory component, the promotion of the vascular additive to it, and what is the presentation that makes it diagnostic. And again, we could sit here and say all day, oh, you're red, you must have rosacea. Well, that's not the case when we see papules and pustules and say, okay, well, is this acne or is this perioral dermatitis? Right, so there's an inflammatory, cascade that I keep referring back to. I think that's where we're also going to learn a little bit more about the ocular component. And many of us who think about rosacea and the ocular side are kind of analogous to those who talk about psoriasis and the arthritic side. Are we not screening enough? Are we not doing enough to test for it? And are we not covering our base when we think about just using topical therapies alone? But more importantly, like I said before, are we doing enough to remedy the problem, not just bandage the problem? And I think that goes back to why we were using our therapies in the first place. And for decades, everyone said, well, why are we using topical metronidazole? What does it even do? It's a macrolide antibiotic. Is it actually even doing something to the process? But again, we've seen a lot of reduction in the reactive oxygen species, some of the neutrophil-generated inflammatory cascade, and again, it's been shown to work, right? I mean, that's really what was the bottom line, whether it's the yellow tube or any other tube. But then we got into tetracyclines, and pay no attention to the first reference on this slide. But the idea is that you get the downregulation of those cytokines, you get the impact of angiogenesis, and of course you also get the understanding that neutrophil chemotaxis is being reduced. What's more important is that, again, the impact of phospholipates, if you remember, that's very important in steroid biology and the prostaglandins, and of course nitric oxide. All of these are impacted by tetracyclines, and it goes back to us explaining to patients, why are we using what they understand is an antibiotic to control an inflammatory process? And it just comes back to a simple discussion of the building blocks that the host skin component makes to create rosacea. So again, all of this discussion, it flows downhill when you think about inflammation. But again, as Linda said, we have to bridge together, where the vascular part of that lies in. And as she referenced, the impact of adding Brahmana Dean to ivermectin, clinically it makes a lot of sense. From a inflammatory side, it also makes sense when you think of, okay, ivermectin has strong impact on interleukin 10, on tumor necrosis factor, on some of the other cytokines that are very important. And again, the promotion of reactive oxygen species and the free oxygen radicals that are part of the equation. And again, the patients are going to look up and say, well, this is a parasite drug. I don't have parasites. Well, the Demodex, story aside, if there's a hypersensitivity response to Demodex, similar to what we think about delayed hypersensitivity response or with, like we do with scabies, the question becomes, are these inflammatory mediators being modified with the application of ivermectin topically? So again, these are some of the drugs that are in the pipeline. Again, we mentioned topical minocycline, both in a foam and bivasic gel a couple times during the meeting. There are some purified neuropeptides coming around, again, to look at specific inflammatory mediators. Different antibiotic derivatives are coming. And whether newer vascular agents are coming, we'll see where they actually have more of an approach on Dr. Steinhoff's graph. So again, inflammation might be the basis, it's the bridge. In just my perspective, you think of, again, what's going to change the process rather than change the symptomatic outcome with rosacea. And I think that's where, again, just approaching the vascular side is incomplete. Just approaching the inflammatory side probably is also incomplete. And the bridge between the two may be, somewhere in between, if you will. But I think rosacea as an inflammatory dermatosis makes a little bit more sense as a classification. So again, I think we should all just take a vow to treat rosacea as an inflammatory disorder. Thank you very much.
Thank you, Neal. So what I wanted to do at this point is take a lot of information about inflammation and the vascular component and try to bring this together with some summary points and discussion. And I think the way I look at it, these people, their skin is wired differently based on many of the things that you heard, and we're just beginning to learn about it. Individuals that react with rosacea have rosacea-prone skin, which behaves differently than so-called normal skin. And there have been a lot of identifications in the literature of why their skin is physiochemically different, which we won't go into here. But the bottom line is, as you heard, they have neurovascular dysregulation, which produces both a vascular response and a pro-inflammatory response. I think the bottom line we heard from both Linda and Neal is there's crosstalk between these different mechanisms that could lead to different phenotypes. And even with the augmented immune detection and response that we get with innate and acquired immunity, there's inflammatory pathways that are triggered, but that also leads to some vascular responses. So regardless of how you look at it, with these different diagrams that are out there, you'll see that there's a lot of this information coming together from a variety of different sources. Erythema of rosacea is not just one thing. It's produced by a variety of different pathways that lead to erythema of rosacea, whether it's papules and pustules with perilesional inflammation and infiltrates that lead to erythema, vasodilation, chronic dilation of the blood vessels that leads to the background erythema, just barrier impairment that leads to inflammation and erythema due to transepidermal water loss. So when we talk about erythema in rosacea, we really have to realize there's a lot of factors contributing to that. But I think the bottom line here is this is a work in progress, and as much as we love rosacea and we want to think that we understand it and that we have it all figured out, we really don't, and we have a long way to go. So what I thought I'd do is wrap this up by talking to Neal and Linda and hopefully contributing myself, is where do we think we are right now? We have all these pathways and areas that Linda referenced and Neal elaborated on. So if we look at the two main presentations of rosacea that we see, whether it's patients that have this background erythema that may get intensified with acute vasodilation or flushing with papules and pustules and have some erythema contributed from that, or they don't have papules and pustules, but they still have erythema and both over time have telangiectasias. How do each of these affect how you're going to manage the patients in what you're going to utilize? So Linda, why don't you start?
And I think that's, if you take home nothing else, It's that when a rosacea patient comes in, just look at them for a second and determine what do they have and what are they concerned about. So if a patient comes in and they have telangiectasias and background erythema, if you don't do some kind of a destructive device to get rid of their telangiectasias, no matter what you do, you're not a good dermatologist because you didn't get them better. So you can take away their papules, you can take away their redness, but if they have telangiectasias, you're going to have to address the telangiectasias. If they come in and they have redness and they have bumps, and you give them a topical anti-inflammatory, you give them topical metronidazole, or you give them topical ivermectin, and you send them home, they're not going to be completely satisfied because you address that and that. So you have to look at them and tease out all the different pieces and then work towards each one of those pieces in order to get a more holistic approach.
I think that's important. I think we also have to remember that azelaic acid, which is available as a gel and a foam, there's actually also data in humans that show that it affects some of these pathways like cathelicidin, things that we're now identifying ivermectin also does, and the tetracyclines do. Neal, do you want to add to that?
Yeah, I think of the way that we were talking about trials. And trials are about monotherapy, responsive monotherapy. And in the real world, many of us are not just going to use monotherapy for the majority of these patients. And Linda says it right when we talk about erythema. I look at static erythema, the patient who's always red, and dynamic erythema, and what makes the dynamic erythema worse for them. And with that comes, okay, then I think where's the process being countered, by which mechanism or what have you. And you mentioned azelaic acid, comes in a foam. A couple of these newer things are coming in foams and gels, and we have ivermectin, which is a cream. And you look at this patient and you say, where's the component of the epidermal change or anything else that drives you to which vehicle? And the answer is none, right? So the real question then becomes, which active ingredient is going to do more in combination? And Linda showed the Brahmana Dean ivermectin data. We've seen a lot with Rosacea and that strength of antibiotic with some of the other topical agents. I think the point of the exercise is we're not just looking at which one agent or which therapy is going to do the job. We have to think about the process of what makes the erythema, what makes the papules, and which is going to counteract that. Right. And that's the difference between remedy and bandage.
Right. And you're referring to the trials, monotherapy. Those are the phase 3 pivotal trials to get the drugs approved. But in the studies where we do have some combinations, we are seeing benefit of adding two agents together. Yeah. In the case of the Brahmana Dean or an alpha agonist with a drug that affects papules and pustules.
And one of the things we all remember is from all the doxycycline trials and everything else is there is an erythema assessment that the investigators fill out. And even with the IgAs improving, or like we talk about moderate to almost clear, there's also an erythema assessment with the majority of these agents that say, look how less red these patients got.
They're less red, but that if you're dealing with something that's treating perilesional erythema, it's that component of it. They still have persistent background erythema that you have to address with another type of therapy.
Is that the analogy of itch with atopic dermatitis? They say, well, the itch improved. Well, is it because the inflammation improved? Same thing that goes with the erythema. Is the inflammation improving, therefore is the erythema
improving? The erythema is not just one thing. The erythema is coming from a variety of different sources, and that's what we forgot. In the original studies, we always looked at counting papules and pustules and grading erythema. What percentage of patients got at least a 1-grade improvement in erythema? So we'd say 50 or 60%. That didn't mean the erythema improved by that amount. That was just the number of patients that got maybe just a 1-grade improvement. So I think really to summarize here, would we agree that combinations addressing different components of the disease are really of greater value?
I agree, but I want to make a plug for skincare, and you have to address adult women because they don't understand that their toners and their scrubs and all the stuff that they bought at Bath and Body Works and all these different places that they think they're doing a really great job with all the fragrance products and everything and alcohols, that's not okay. So the first thing, and you're going to get them better by just simplifying the regimen and saying, let's just put all that stuff away. Just gentle cleanser, gentle moisturizer, and a sunscreen, I think is half the battle. Improve the barrier and just stop doing the things that are harming you.
Oh, absolutely.
In
Anything
fact-
that got you to seeing me today, let's put that away. Let's start over.
Helen Torok actually had a great article in Cutis, it's some years back, and it was men and women, the products that they used, and a lot of them were personal hygiene products that actually were triggers in their rosacea. It could be shampoos, it could be aftershave lotions, it could be colognes or perfumes, or a variety of different things that more women tend to use. So I think all of it, packaging it all together, looking at the patients on what's bringing them to why they're there, as you say, is extremely important. Yeah. Any final comments from either of you that you want to say?
Well, I think it's a really exciting time. I think we continue to learn more and more, and the more we learn, the more we understand we don't know. And the good news is we have some really great drugs, and we have some really great drugs on the horizon.
Yeah, right. No, I would agree. I mean, being part of the process of seeing where the new treatments can come from has been exciting. But I do go back to, again, I think rosacea is the most overdiagnosed and misdiagnosed condition.
Because of photo damage. People are calling photo damage
red.
rosacea. Everything that's red.
Everything that's red.
Neal did bring up sub-antibiotic dose doxycycline, and I think it's important to remember that the significance of that is not that there's anything magical related to it's doing something different that doxycycline is doing other than avoiding the antibiotic selection pressure. You're really getting the anti-inflammatory effect against MMPs and some of the other things that Neal showed. But what's important is you mentioned ocular rosacea. The information that we got on tetracyclines that we translated to using to treating rosacea on the skin came from studies first with ocular rosacea. I learned this from Guy Webster, that MMPs and some of those mechanisms that we talk about with skin were first identified in the eye. So I want to thank both of you. I think this was an exciting discussion. I think we really came out with a tie because you both brought together that everything is contributing and everything is crosstalking that we talked about. The tiebreaker we're going to decide in the back.
In the pit of misery.
Yeah, in the pit of misery.
Yeah.
Right.
Thank you.
Thank you very much. Okay.